Good morning, everyone. I'm very happy to be here in this really inspired space on this rainy day. Very grateful to Georgetown for providing this space, for helping organize, and USAID, of course, for all the work that you've done. 4 months ago, here in Washington, D.C., UNICEF and USAID jointly convened the Population-Level Behavior Change Evidence Summit for Child Survival and Development. For UNICEF, we consider the summit to have marked a turning point in our work on social and behavioral change, and we really remain deeply grateful to USAID and the colleagues involved for their tremendous vision, the technical expertise, and the collaboration that made the summit possible. The summit aimed to offer recommendations for shaping social and behavior change demand and practices to improve maternal and child health outcomes. It had a strong focus on the faith-based pledge that you all know about and many of you were involved in that emerged from the Child Survival Call to Action in June of 2012. So thank you for those promises and for focusing us on what is truly important in child survival. The 10 promises of that pledge became the search terms for a monumental collective effort to review the science and evidence. The review considered what has worked to change behaviors of individuals, families, communities, providers, and health systems to keep the promises that have been made to children. More than 100 researchers and practitioners from around the world helped develop focal questions that were the basis of the evidence search. Thousands of scientific publications were collected from peer-reviewed literature. They were sifted, they were weighed before they were distributed to 6 evidence review teams. The teams brought in additional evidence from the gray literature and from their own professional experiences. They reviewed and analyzed the evidence, and then they drew conclusions and made recommendations. UNICEF and USAID worked together in the truest sense of partnership to hold 3 pre-summit consultations in Addis, in Delhi, and New York, culminating with the summit event in DC this past June. The summit brought together more than 200 global leaders to consider what needs to happen to change health-related behaviors in lower and middle-income countries, to reduce under-5 mortality and help children reach their full potential. On the final day, we organized a media festival showcasing effective use of radio, TV, film, and social media in health programming. So what did this all lead to? As a result of the summit, global child survival and development partners issued really what was a clarion call to unleash the power of science and evidence to shift social norms and drive sustainable behaviors for child survival, early child development, and well-being for generations to come. We obviously don't need to convince all of you here today about the importance of this effort. That's what you do every day. But I would like to stress the magnitude of of some of the challenges that we face. Just for a few, and just to highlight what many of us already know, less than 40% of infants are exclusively breastfed for 6 months. Only 31% of children suspected of having pneumonia receive inexpensive antibiotics. Only 35% of children with diarrhea receive oral rehydration therapy, and only 63% of children use hygienic sanitation. Before I sum up, just a few other points, just to share a few examples of what the Evidence Summit found does work to start changing these behaviors. The first is that really culturally appropriate nutrition messages can change infant feeding practices and improve child growth despite impoverished conditions. There's robust evidence showing that community-based breastfeeding support groups work, especially for young mothers and those under stress. There's also moderate to strong evidence that counseling is effective in promoting breastfeeding practices. There's strong evidence that providing soap and initial communication about the benefits of correct and sustained hand washing by caretakers and toddlers after using latrines and before preparing and eating food can drastically reduce mortality and morbidity among children under 5. And finally, the evidence supporting the implementation of the WHO Essential Newborn Care Program is very strong. Training providers to apply evidence-based protocols to improve healthcare delivery has a powerful impact on neonatal survival and health. In some cases, the effect sizes of social and behavior change interventions are truly astonishing. A recent study in Bangladesh highlighted a package of immunization-specific interventions in an urban slum in Dhaka that address both demand and supply. the proportion of fully immunized children under 2 years of age increased from 43% to 99%. Dropouts decreased from 33% to 1%. In Malawi, implementation of Option B+, a new treatment protocol that calls for lifelong triple ARV treatment for HIV-positive women who are pregnant or breastfeeding, had dramatic positive results. The number of pregnant or breastfeeding women enrolled in treatment programs increased by 748%, with 77% remaining on treatment 1 year later. This translated into projected mother-to-child transmission declines from 40% to 5%. The summit also resulted in important products that will feed into action plans for policy, program, and research recommendations, all grounded in scientific evidence. Faith-based organizations with your 10 Promises to Our Children were the starting point for the Behavior Change Summit. Evidence and experience of the work of faith communities was featured during the summit itself. So at this meeting today, you're taking your commitments to a new level by working to further engage faith communities in country strategies for maternal and child health planning and action, and systematizing and sharing your tools and models for behavior change and accountability. Thank you for being there at the beginning and for being part of the ongoing fight to end preventable child and maternal deaths.
Thanks, Liza. And there'll be, stay tuned on this station. There'll be a lot more coming out from this Evidence Summit, one of the most exciting meetings. I heard they had an awesome facilitator at that meeting too. I don't know. Before we move forward, I also want to take a moment to introduce Mark Brinkmuller, who's the director from USAID, the director for the Center of Faith-Based and Community Initiatives. I think most of you in the room know who Mark is. He's the rock star standing in the back. Okay, so I'm going to now turn things over to Catherine Marshall, who is sort of the kind of person I want to grow up to be like, because she's got all these incredible titles. She's the executive director for World Faith's Development Dialogue. She's a senior fellow at Georgetown's Berkley Center for Religion, Peace, and World Affairs, and a visiting professor at the School of Foreign Service. Another rock star. So, Catherine, I'll turn over to you. Thank you.
I think there was a slight technical hitch there. Well, first, let me add my very warm welcome to all of you. We've all been corresponding actively over the past few weeks, and it's very good to see something actually happen. I also want to add a welcome to Bill Vendley, who's snuck in, who's the head of Religions for Peace, who's an important, even critical ally in all of our efforts here. So what I'm going to try to do is first talk a little bit about why we're all here and what it is that's motivated us particularly. I want to focus on the background work that we've done, hoping to make this meeting as effective as possible. Some of the interesting examples that we've come up with as we've done our mapping work, a few general conclusions, and then some of our hopes for this meeting. First, I think our inspirational speakers, Geeta, Carolyn, particularly, have really highlighted the theme of the breadth and the exciting work that's being done by faith-inspired organizations, the power that they bring, the vast experience, and the hopes that we hold. And I think what we also need to highlight is that this experience in the overall global setting is appreciated by a few wise people, like Geeta, for example, but not necessarily by the entire health and global development world. And so we have to ask ourselves why that is. And a part of it is a lack of knowledge. And a lack of awareness. And it's for that reason that at Georgetown and in the World Faith's Development Dialogue, which is another story, but it was born in the World Bank about 12 years ago in an effort to try to bridge this divide. We are very much aware that there are gaps in evidence and understanding that affect this very complex, let's call it an octopus-like world of faith. And so bringing the evidence that we just heard about together with the evidence that comes out of the lived experience of so many communities, the thousands of years of their history, is an important part of the global effort. So we are very convinced that more and better coordination can enhance the impact of the work that you are doing, but also the work that global health programs are doing. And we are also convinced that there are nuggets of experience that are not taken into account, that are not appreciated, of insight, of wisdom that comes out of lived experience and to a degree out of the broader effort. So that's why we're here. More specifically, the World Faiths Development Dialogue, in this case, is working to carry on the torch that was described earlier of the 10 promises for saving children through behavior change, which we have done very much in collaboration with the Center for Interfaith Action on Global Poverty and now with Religions for Peace. So this is a continuing Olympic torch that we are carrying. And I would like to acknowledge the specific collaboration of Katie Taylor and SIFA in goading us into doing some of the work that we've been doing here. I would also highlight that it was only a couple of weeks ago, or I think it may even still be dribbling on, that at the United Nations, there was a great focus on the Millennium Development Goals and on what's coming next, the whatever they're called, Sustainable Post-2015 Goals. There, I think, is an awareness that the kind of accountability that Gita was talking about, the sense of if you treasure what you measure what you treasure, that the idea of holding governments, of donors, of religious institutions to account for promises is a fundamental reality in the global world. But there's also a ferment of discussion of what it all means and what's happening next. And to date, I don't think that this faith dimension is a central part of that discussion, and it needs to be. And so I think that's one of the elements of what we are talking about today. So turning to the work that we did, and I hope that you all have had a chance to look at the document, the 10 promises. I think first, we were very pleased that we saw a broadening of the promises to include maternal health. And I think we all know that maternal health is one of the most critical of the Millennium Development Goal promises. It is one where there has been the most disappointing progress. And there's a new focus, but not necessarily translated yet into results. So the 10 promises framework now includes promises to children and promises to mothers, because the two are, I don't think we need to describe why, inextricably linked. So our contribution was to produce a mapping of faith efforts involving these 10 promises approach. And we started with 3 fundamental questions. The first one is there a distinctive role for faith groups? And I want to emphasize that we use the term distinctive, not unique. In fact, I strike out unique whenever I see it because, first of all, it's very easy to prove that it's not true. And secondly, I think it denigrates the kinds of collaboration and breadth of vision that we're looking at. But it's not difficult, and Carolyn gave us 11 wonderful examples, to look at distinctive roles and the vast size and the importance. So the first question was, what are these distinctive roles on each one of these 20 promises? The second is, what significant things have faith groups globally and in the U.S. been doing relative to the promise? And what we tried to do there was to look at a broad range of faith groups and communities, not just Christian, let's be very clear, because those are the easy ones to look at, but to look right across. And then third, to look at how these different groups are measuring progress, and to try to cite for each one of the 20 promises an example of a successful initiative or intervention. So clearly, and you can hear it in the discussion today, we're talking about the many different dimensions of these faith engagements. We're talking about advocacy at the global level and at the national level. I think the importance of advocacy vis-a-vis governments is particularly important. We're talking about actual delivery of services. We're talking about the role of the large faith-inspired organizations, as well as the smaller ones, which are much less clearly present on the radar screen. And we are, above all, because we're looking at it from a very human point of view, we're looking at the very complex role of faith-inspired organizations, institutions, leaders, groups at the community level, and at their role in behavior change. We focused particularly on the high burden countries, particularly Ethiopia, India, Nigeria, Zambia, DRC, Bangladesh, Liberia, and Senegal. And I would like to pay a special tribute to two of my colleagues, one of whom couldn't be here, Lynn Aylward. She had an illness in the family. And Alana Tornello, who put in, I cannot describe how many countless hours in combing and trying to sift the evidence that we could find. We also did draw on our own past partnerships and experience. As I said, we've been in this business of mapping, of trying to figure out who's doing what, where, why, with what resources, and with what impact for the past 12 years. And so we drew on that. So very quickly, to give you just some of the interesting examples, and I hope that will entice you all to read the report carefully, and there will be a quiz at the end of the day. In Cambodia, Wat grannies are promoting better breastfeeding practices. So the idea of Wat grannies, I think, is very appealing. In Nigeria, despite what you read, wise Muslim leaders are working to counter the anti-vaccination rumors with assistance from UNICEF and a number of other partners. In Ethiopia, the Orthodox Church priests check children's immunization status before they baptize them. In Brazil, the remarkable Pastoral da Criança mobilizes an army of Catholic volunteers and public-private partners in fighting malnutrition. In Pakistan, mullahs encourage vegetable gardens and post-flood food security for children. In Rwanda, the HIV/AIDS healthcare initiative of the Peace Program that's supported by Rick Warren and Kay Warren leads grassroots efforts to improve child health services. Compassion International runs a Water for Life program that includes the provision of clean water to an entire family as a component of their work. And in India, Christians have mobilized to better options against dry latrines to deal with some of the caste issues there. So there are many, many other examples. So to give you just very broad conclusions, faith communities and leaders representing all of the world's major religions are already involved in advancing every one of the behaviors, so that there is an extraordinary gold mine of information. They're everywhere at all levels of society. And some of the beliefs among this vast diversity can be harmful, but many are moving in exactly the direction that we want to go. There are issues, and This report did not focus as much on the issues and the problem areas, but I think that it's very important that we do that here and in the follow-up. There are very large issues of coordination. There are still very large gaps in knowledge. There are many complexities in partnership. What do we mean when we talk about partnership, and what are effective models of partnership? And how can we improve the goal of accountability? Those are some of the issues that we came across as we did this work. So for this meeting, we have great hopes. We would like to see coming out of it both a broader understanding of where the gaps are in our knowledge, where the evidence is and is not available, and where it is and is not being used. We would like to see some avenues so that the faith worlds can be more actively involved in this global effort, as well as national efforts that are reflected in the MDGs and the post-2015 framework. We think that this 10 promises approach, which is very much a close cousin of the MDG approach in its emphasis on focus, in its emphasis on accountability, on measurement, offers an extraordinary way of achieving that goal. It's inspirational. It offers very practical tools, and it gives us something to look forward to, but also to look back on it. And you here are the experts, and we look forward to working together on this.
Sorry about that. I got lost in the stacks. Okay, we are going to turn things. Thank you, Catherine. Thank you very much. We're going to turn things over to the Health Communication Capacity and Collaborative Project. We have Susan Kern, who's the director of Center for Communication Programs at Johns Hopkins University, and Heather Hancock, who is the from the project, the HC3 Health Communication Capacity and Collaborative HC3 project. She's the program officer for the capacity building team, and they are going to showcase to you give you a little bit of a background on SBCC, social behavior change communication, and then showcase one of the tools that we are developing and putting in place for everyone to use. One of many tools, I should add. So I'm going to turn it over to you, Susan, and.
Good morning, everyone. Great to be here. Want to thank everybody for providing this platform to talk a little bit about this convergence, this great convergence and exciting convergence of the faith-based organizations, the Child Survival Agenda, the 10 Promises, and SBCC, Social and Behavior Change Communication, as we refer to it. And I want to start really, before I jump in, to say I kind of have to apologize on behalf of the community of communication practitioners, because honestly, I think we do not the greatest job in helping others outside of our community understand exactly what it is we do and how we do it, because we use a lot of different terminology and we change it. And so I think we need to do a better job at helping everybody else beyond our set of practitioners understand exactly what we do. But I want to say, regardless of what we call it, whether it's BCC or IEC or advocacy, social mobilization and communication, or health communication, or SBCC, as we refer to it here, social and behavior change communication, the fundamental thing I think we could all agree on is that what we are really doing is using one of the most powerful and fundamental human interactions there is in the world, which is communication, to influence positively the knowledge, attitudes, behaviors, social norms of individuals and communities to improve their health. So even though we speak different languages, we're all doing the same thing. And when we talk about communication programming and look at a strong communication program, there's a couple key elements that we tend to think about. One of those is that we use research to actually help ground and understand the program. So we don't just jump in and do communication. We really use evidence to help shape and define the program. In shaping and defining the program, obviously we want to have very clear objectives. We want to know where we're trying to go, what behaviors we're trying to change, and what level of change we're trying to have happen. And that research and theory that goes along with that really helps to shape the communication interventions, the messaging, identifying the audience. And that theory, in a way, along with the evidence and the research, helps us to understand how we're going to get there, not where we're going, but how we actually understand our processes and how we think they are going to affect and impact on behavior at the end of the day. Another key element we look for in good, solid communication programming is really use of multiple channels or media, looking at community level, mass media, radio, TV, whatever those opportunities and resources are locally in the context, to bring together so that the media and the channels are mutually reinforcing, and also to work at different levels of the structure, from the very high environmental level, policy, advocacy, influential level, to the service delivery system, down to the community level, the individual and the household level. So we really want our systems, our communication systems and channels operating together in a mutually reinforcing way. And along with that also would be a strong focus on monitoring and evaluation that's built in with the program from the outset. We've talked already about accountability here. Well, we want to be accountable in our programs to understand what we're doing, are we having the impact, and how can we improve the programs at the end of the day. And we can't do that without that proper monitoring and evaluation. So those are some key elements. Fundamental to all of this is an understanding that behavior change doesn't necessarily happen overnight. People go through a progression. So they go through a knowledge and awareness to a contemplative reflection to actual action. And so we have to be cognizant when we do our programming that this is a process that we're moving people through. When you look at the key promises in child survival, it's just so striking, how much has already been done in this area in SBCC. We've seen so many successful examples of how SBCC has been used to impact child survival outcomes. Obviously, the faith-based organizations have been hugely involved in this effort. And as was just said, so many fabulous examples from the Evidence Summit of the work that's been done in this area already with faith-based organizations. I think when you look at the list of interventions or behaviors that we're all trying to work on here, it's just hard to imagine how we could get anywhere without using communication in these. And I would posit that, for many of these, I can't even think of another intervention that would be more impactful than the use of communication on these behaviors. One of the things we do and have done over the decades that we've been working in the field of social and behavior change communication is to develop and use tools with our counterparts in the field that really help break down a little bit the complexity of how you approach communication programming on the ground. And so this is one of our, I would say, most basic and important tools that we've used for years now, and we work with our local stakeholders and go through this planning process, if you will. And really what it is, as you can see, is just a step-by-step process for planning. And I know all of you are involved in planning of all sorts and shapes, so it shouldn't look too astounding to anybody. But I want to really just focus a little bit on the first two steps from a communication perspective. And that first is the inquiry, which really sets the foundation for the entire program. And that's where we are looking at the local context and the research and really using that to ground the program in. And so we're trying to understand what behaviors we're trying to change, what the issue, how they're already in play on the ground, who influences those behaviors, what are the resources, and what is the context already there on the ground on which to build. And so I want to just kind of note that in this stage, we're really working and talking to a huge range of stakeholders. And so part of this would be, the social and cultural aspects of the context as well. And we take this information and move into the second stage, which is designing the communication program. And during this second step, we very much have a whole range of stakeholders, again, at that table. So not only the health professionals are sitting there, as one would expect, and media professionals, community mobilization experts, but a whole range of civil society organizations as well, including faith-based groups. I think from my very earliest days of starting work in Nigeria from 1985 up till today, it's hard for me to think about a program that we've been involved with that the faith-based groups weren't sitting with us at the table on this agenda. And I think, as rightly pointed out, the faith-based organizations are part of the fabric of society and therefore such an essential stakeholder on these agendas. And just by nature of the work we're doing, communication is very multidisciplinary. So we do have, a broad set of folks at that table, including university partners, private sector researchers, et cetera. And so that second stage, is where we're kind of shaping the program with that set of stakeholders. The third step is taking those ideas and sharing them with the audiences and really trying to verify whether the ideas and concepts that have been come up with by the team on the ground locally resonate. Are people understanding what we expect them to understand through these materials and interventions? Fourth step is the implementation itself, and the fifth kind of comes back around to the monitoring and evaluation I mentioned, feeding back into a new cycle. And around the edge of this, we have this theory and participation and capacity strengthening. And these really run throughout the cycle itself. So we don't drop one at the beginning of step 1 and pick it up again in step 5. We really see these as integral to the program cycle throughout. And what we found on the capacity building is that as we work with local counterparts, when we go through this cycle, hand in hand, it's very empowering. People learn and see each of the steps of this process. And once they've gone through this cycle in a very systematic way, they can take and use this and apply this to lots of other things that they're doing. I'm going to just share very briefly a couple slices of a few programs to hopefully try and help illustrate how this works in practice. So I'm going to start with Tanzania, and this project is USAID funded through PMI. And the context for the program was addressing malaria prevention and treatment. And for those of you who know Africa and have worked in Africa a lot, you'll know that malaria is just kind of considered something that's there. Everybody gets it all the time. It's like the common cold. You go get your drugs, you do what you do and you get through it. And so the challenge here was to actually kind of increase people's perception of the burden and help the community and leaders understand the terrible toll malaria actually takes, but at the same time is increasing that risk of perception around malaria, giving them the tools and skills they needed to actually take practical steps to prevent malaria. And so this project operated, as I mentioned, at all levels of the system. We had one of the former presidents of Tanzania talk about malaria issues. A number of other influential leaders was on TV doing these spots as well. And we know from our research and work in many, many different countries that what leadership does matters. And I think you all know that very well. We used a lot of mass media, a lot of radio programming. We had spots on use of bed nets, malaria treatment in pregnancy, seeking prompt treatment. We also had a children's program, a children's radio program that we did on Saturday morning. And the idea here was to reach out to children and give them the information around malaria and how to prevent it and how to treat it, so that they in turn could take action on their own, but also speak to their parents. And we have a great story of one girl who listened to the radio program, and she'd been trying to get her dad to buy a bed net, and he said it cost too much. She finally made him listen to the radio program on Saturday morning, and immediately after, he went out and bought a bed net. So we know that the kids themselves can have influence on their parents. Another component of this program was a full-length feature film following in the Hollywood tradition, and in Tanzania they call it Swallywood. So there's a whole burgeoning media industry, and we developed a love story. And in that love story, we embedded issues around maternal health and malaria. And the feature-length film was taken out into communities. It was broadcast on TV. It was shown in the small video houses. And it's a way to kind of get out to the community. We refer to that as kind of the mid-media. And then at the community level, there are a lot of different mobilization activities, including roadshows. And I think over several quarters, we reach millions of people just through those community activities alone. And at the health system level, there were a set of print materials for the providers themselves around these key malarial issues. So just a quick indication of some of the impact. For those who were exposed to the program interventions, you see a much higher uptake of bed net use than those who were not exposed to the program. So that's just an indication of the power of communication. The next project I want to give you a slice of. Does anybody know? I'm going to try and play a spot, and this is where everything always breaks down. But in Ghana, again, a USAID-funded behavior change communication program that we're working on, which is covering a whole bunch of different health areas. One of the topics under an umbrella campaign is the Good Life, and part of this is the good food for good life. In fact, Beth Ann, I think, was in the mission when we were launching this program. So it's just nice to be able to share this with her here. And this part of the campaign was addressing malnutrition and anemia issues, really trying to get people to understand what the proper complement of feeding is during weaning, to engage in exclusive breastfeeding, etc. So I'm going to try and show you just a TV spot from this.
We want our children to be healthy and happy. That is why it is very important to feed them from the 3 food groups starting at 6 months. And the 3 food groups are...
Bodybuilding group. I am Baba. Feed your child bodybuilding foods every day like meat, fish, groundnut paste, and beans.
Protecting group. Fruits. I am Fruticaka. And vegetables. I'm Pain Vegetables. Together, we will protect your child from diseases and boost them up to keep them glowing with health and feeling fine.
Energy group. I'm Kofi Energy. Starchy foods, fats, and oils will give your child energy and speed. Just watch me go.
And I am Mansa Milk. As you add other foods starting at 6 months, continue to breastfeed your child every day for good growth and strong bones.
And if you follow this plan, your children will
grow,
glow,
and go.
Good life goes with good health. Good life. Live it well.
So that would have other media and interventions around it. So that's just a slice of that nutrition intervention. And I think the data literally walked in the door yesterday, and we have some very good preliminary indications. One is that zinc, the use of the sale of zinc tabs for treating diarrhea went up almost threefold in the quarter following the launch of this campaign, to about 8 million tablets, I think, a month. It looks as if also between the baseline and the midline, we've seen about a 20% percentage point increase in immediate breastfeeding after delivery. And we're also seeing some good impact in exclusive breastfeeding during the first 6 months. Again, very preliminary data, but we should be able to share a little bit more on that later. The next program I just wanted to reference is one we did in Pakistan around maternal health, and this was part of a very large program that had many communication and service delivery inputs. But I just wanted to mention one particular intervention that was done with the ulamas, and where we were working in a very very rural, conservative area of the country, and the men and women in those communities very much illiterate. And so the intervention was a partnership with the ulamas, the religious scholars in that area, who became conduits for information around maternal health issues, seeking postnatal, antenatal care, postnatal care, breastfeeding, needing to get transport funds ready, to have permission for the wives to travel, et cetera, if they got into trouble. And I think, again, some interesting findings from this. We did not ask the ulamas to ask their constituents in the sermons to talk to their wives about these issues. We really were just asking the ulamas to share the information with their congregations. So you'll see that not many of the husbands talk to their wives, because that's not really culturally acceptable in that context. But of the small percentage of the husbands that did speak to their wives, there was a pretty good outcome in terms of this shift in attitudes about these maternal health issues. And I think, importantly, you see in this slide, the knowledge of men who received this information through the ulamas greatly increased around any number of these issues, including the exclusive breastfeeding, planning for money, the planning for transportation, and the need for the 4 antenatal care visits. So again, you all know this. Those are very powerful results, and it is the faith-based community that really is the group on the ground that has the connections, has the respect, and has the influence and the ability to bring these key messages to their constituents. The Health Communication Capacity Collaborative, which is the project that brings us here, we refer to it as HC3, and you know why, because it's such a mouthful to say, is a USAID-funded 5-year global project that is helping CCP and its partners, Management Sciences for Health, NetHope, PSI, and others, to do this type of programming on the ground in a variety of settings. But as you can tell from the name, really there's a huge focus on the capacity strengthening agenda on this and the collaborative nature of this project. And there's many approaches we are taking to build the capacity and strengthen skills out there in social and behavior change communication. But I think today we're just going to highlight quickly. I'm going to highlight one, and then I'm going to turn it over to Heather to walk you through one of the tools. But I think that what I want to say here is that we really, through this project, have a very strong desire to make the tricks and the trades of what we do in communication much more accessible, easy to use, and available to a much wider set of stakeholders. So if I had to summarize what the Health Communication Capacity Collaborative is about, it really is about this. How do we strengthen the broad base of implementation out there to make the best use of communication to really improve the well-being and the health of communities and individuals out there? This first tool, there's a folder in the other room that you might pick up a little bit later in the day, but the first one of the tools that we have that we'll be launching formally in November is something we're referring to as the Health Communication Marketplace. And this marketplace is meant to be a convening space, both virtual and face-to-face space, for people who want to engage on this agenda. So it's a place where people can exchange information, have conversations. It's a place they can go to learn about social and behavior change communication. They can get resources. They can network to other resources out there. It's really meant to kind of be a bit of glue for everybody who wants to get engaged on this agenda, to provide, to get them what they need to be able to effectively implement programs out there. The second tool is the Health Compass, and this is a repository, a curated repository of how-to tools and samples of materials that Heather's going to walk you through. And I just want to say that we've done our best based on our experience to try and figure out what will be helpful out there. And we've talked to a lot of different stakeholders in the process, but we really ask of all of you sitting here today to say whether we're hitting the mark, whether we're missing the mark, and really help us to figure out how best we can do our job to help others out there do this type of work in the field.
Good morning. I'm very excited to be here with all of you. While we get set up, let me just give a brief introduction to one of the reasons why we created the Health Compass tool. As I've been traveling, I talked to a lot of people who tell me that they're thrown into health communication without a lot of formal training or background, and they have bosses or donors who are really expecting them to produce high quality communication materials without a lot of knowledge of how to do it. And in part, the Health Compass is an answer to some of those requests that I get of people asking me, I need tools, I need to know how to do this stuff. So that is the Health Compass. It's an interactive platform that houses packages of the top quality SBCC resources available. And it really does focus on SBCC. There are a lot of collections out there, but this one focuses on building the capacity of other people to do SBCC. And we have two major types of tools in our collection. As Susan mentioned, we have the capacity strengthening tools, or the how-to. So if you want to figure out how you actually design or implement or evaluate SBCC programs, these are the how-to tools that are in the collection. We also have project examples. So once you've kind of figured out how you do SBCC, then you're able to take a look at really excellent work of what other people have done that's out there. So it really builds on the way that people naturally learn in the process. Usually you learn how to do something, and then you try to look at what other people have done to model your own work after it. So we have both of those available in the Health Compass. Just to give you a quick picture of what kinds of things are in there, the tools or the how-to materials are organized by the strategic process, kind of like the P process that Susan showed just momentarily. We have articles that are on the foundations of SBCC. We have on the analysis or the design, development, implementation, monitoring and evaluation, and audience participation. So you'll find resources in each of those categories on the Health Compass. For the project examples, we've organized them by intervention level. So you'll have anything from the national level down to the community and health facility and individual levels. One thing I just wanted to mention is that the Health Compass offers materials in packages. What we find in SBCC is that a one-off poster or a TV spot is not something that typically changes or sustains behavior change. So what we've offered here in the Health Compass is trying to capture the way that SBCC is really done in packages. So we don't have just a poster. We have the counseling materials that went with that, the community interventions that went alongside that. So it's a package of materials. We also offer here process documents. A lot of times people ask me for design documents or scripts or the creative briefs. And so what we have here is everything that accompanies the package of materials so that you can really figure out how you would do SBCC to make changes in child survival and maternal and child health areas. Lastly, I'll say that the Health Compass highlights what we say the best of the best. People don't want to sift through site after site or tons of resources to find what's actually good out there. And a lot of people, if you're new to the SBCC field, you don't even know for sure what is high quality. And so what we've tried to do is capture some of the best materials here. And when we ask people to contribute, we ask them to respond to two simple questions. And those questions are, was the material developed using a strategic communication process? And then secondly, did it have a positive impact? That might be anecdotal or it might be a formal evaluation, but those are the criteria for inclusion in the Health Compass. So when you go to the Health Compass, you know you're getting something that is of high quality and not just some communication material. Lastly, the Health Compass encourages learning through participation. We call it a learning site because really people learn from one another. This is a place where people can share their experiences using the materials, share how they developed the material and what happened when they actually implemented the material. And in that way, people learn from one another's experiences. And so we hope that through this process, people will be able to learn both as they use and share. So, I just want to take you briefly through what the Health Compass looks like, because this is one platform of many platforms available that may be helpful to the faith-based community here. So this is the Health Compass homepage. I'll try to move this over here. And let me just walk you through a little bit of what's available to you. We have two major ways to search on this platform. The first one is a guided search, which I'll take you through, and the other one is a filtered search. And a filtered search, you can type in your regular search, and then you can filter using the categories that are here on the right-hand side. So you can filter by the stage in the communication process that you want to look at, or the intervention level. You can filter by the communication channel, by the topic, or by regions. And so that's a kind of quick and easy way to narrow down the kind of results that you might be looking for. What I want to take you through in more detail is the guided search. And the guided search focuses on the learning part of our site. And it presents some different topical information on the different parts of the process of communication. And so the first question that you're asked is whether you want to look for project examples or SBCC tools. So let's say that we'd like to look at a project example. And in each question that you're asked, you're also given information so that you have a little bit more background for choosing what kind of materials you want to look for. The second question is what part of the world do you want to look at? We find that a lot of times people want to look at a specific region, and so that's the first question. And for each one of these, you can choose to skip if you're not interested in narrowing your results by those categories. So let's just skip that one. Say we want to look at everything in the world. The third question is the topic area that we want to look at. And given our audience here, perhaps we can look at some of our maternal, neonatal, and child health resources. Next, we try to choose what audience that we're looking for. And again, I thought we might look at the local and faith-based leaders, since we have our audience here. We have a number of audiences. We also have non-governmental and faith-based organizations as well. But we'll take a look at that. Then we choose the intervention level. So do we want national, health facility, community, or individual? For example, we can choose national. And then we lastly choose our communication channel or approach. So we can take a look at print media. Once we've answered all these questions, we can see the search terms that we've used here and then what items are actually available to us. So right now there are 7 items available to us. And I'll just take one of these, the Ulama project, the Paimon project that Susan mentioned. This is a material from that project. And what we have here is a variety of information on that. And then we also have the package, like I mentioned. So if you want to look at the other parts of the package, they are down here. And if you want to look outside a little bit of the box, then we have articles over here that show you that are more things like that are connected to this topic. So these are some basic tools that are available to you. And then lastly, I just wanted to show you one area that might be of interest to you, and we've just barely put together what we call a focus package, and that's a set of materials on a specific topic. And right now we've put together a focus package on faith-based resources. And this is more if you're working with faith-based leaders. But we have the homepage here. There's a little introduction, and then we have tools and the project examples. Just to give you an idea of what kinds of things are available here, we have tools from a variety of organizations on how do we actually go about working with faith-based communities or working with faith-based leaders. And so there's some really excellent resources here from CIFA and from World Vision, all sorts of different organizations. And then lastly, just to show you the project examples, we also have a number of excellent project examples here available on working with faith-based leaders. this is just one resource that's available to you. There are plenty of resources available out there. I know that UNICEF has put together some really excellent resources for faith-based communities and in terms of the mapping as well. And then the Berkley Center also has put together a great package of resources. So we will be working with all of these organizations and communities to leverage the things that are already out there. We also will be this afternoon focusing on creating an advisory council, where we will be able to work with the different organizations who are working in this field so that we make sure that we leverage all the resources available to you. And with that, I encourage you during the break to register. We'll have computers in the room back there where you can register for the Health Compass. And thank you.
Thank you, Heather. And I just want to emphasize that, you know, there are a lot of tools out there, and this is indeed just one of those tools. We do encourage all of you to register. It gives you an opportunity to upload much of the work that you've been engaged in. It gives you a chance to interact with other faith organizations, with other non-faith organizations, NGOs, everyone who's working in this space. It's one of the many opportunities to get more information, to get examples of success stories.